great. Ben Hogan was the guy. For you that don't know who Ben Hogan is one of the greatest golfers that has ever walked the face of this earth. He is what we know as the founding father or the founder of deliberate practice. Meaning that when he was back in the 50s, 40s and 50s, when he was a star golfer, what he would do is that he would practice things in a very specific, meticulous way. And he would break it down into small pieces. If you wanted to label someone as a micro learner into micro skills in order to achieve something great, Ben Hogan was the guy that you would be thinking about. Because what he would do as a golfer is that he would practice these smallest skills. He would take 100 repetitive shots out of a sand bunker. He would take 100 repetitive shots at 100 yards away. He would take 100 repetitive putts over and over again. But what he did differently than most people that do volume practice, like a lot of do, is that he would take notes with his coach and with his caddy of the things that he's doing right and the things that he was doing wrong and change those wrong things. And by doing that, by being meticulous and deliberately practicing with quality as opposed to just volume, he became a near perfect golfer. So perfect that in the 50s, during a Masters tournament, he hit the flagpole twice in a row, okay, on 2 separate holes, back to back, hit the flagpole twice on 2 shots. Not only that, he set the record of the same Masters tournament overall. Okay, the same lowest score record. That's how good he was at being diligent. And that's where he says his success is from. It's not from his talent. It's from his commitment to be diligent in his practice to become better. And that is who Ben Hogan was, the founder of deliberate practice. And now you might be saying, okay, I've heard of deliberate practice, but what exactly is this deliberate practice that people are talking about? Because deliberate practice, because of Ben Hogan, it went into most sports. And most of the education, most of the training and the coaching that's been done in sports now is all micro-learning. It's all diligent practice to correct those small mistakes to make you near perfect. That's what pro sports is all about now, is correcting those small things to make you great. Now, we are starting to see that spill over into the education world with technical skills and critical thinking like we do as paramedics. And so what exactly is the difference between what we do now, or what we call simple practice, and deliberate practice? Now, think about simple practice as a volume practice, where deliberate practice is more of a quality practice. Now, what that means exactly is that let's take 2 basketball players. 2 basketball players that are, let's say they're competing and trying to get 10th overall or above 10th overall in the draft. And they are approached by a scout at the combine, and that scout will go, you know what, you're going to go 10th overall easy if you just improve your free throw percentage. And he says that to 2 separate players, player A and player B. And then those 2 players take that advice from that scout and say, no problem, I'm going to go back and practice that. And so player A is going to say, I'm going to shoot 300 free throws. I'm just going to shoot them over and over and over and over again and try and create some muscle memory in order to be able to do that. And you know what will happen is that they will actually increase their free throw percentage, let's say by 2-3%. Okay, and just keep in mind that free throw percentages are between 85 and 95 in the NBA. They're pretty high. And so he improves it by 2-3%. Let's say he just makes it to 83% or 85% on the low end of average because he's volume shooting over and over again those 300 baskets. But then you have player B that goes home, goes to his coach and goes to his trainer and says, was approached by a scout and he said that if I improve my free throw percentage, then I'm going to go 10th overall. And so and then the coach will go, you know what? Okay, what we're going to do is we're going to shoot 100 baskets every single day. But what we're going to do is we're going to record you, we're going to videotape you, we're going to take notes of what you're doing right and what you're doing wrong with every single piece of your shot. And so they do that, and they do this quality type of deliberate practice, and he shoots over, takes some notes, shoots, takes some notes, looks at the video, tries to figure out what he's doing wrong and differently, and tries to perfect his individual jump shot and his individual free throw shot to make himself better. And that deliberate practice will skyrocket his free throw percentage if he's diligent and consistent with it. And that is the difference between volume, shooting 300 baskets but not paying attention to how you're doing it, and deliberate and quality where you're shooting only 100 baskets but you're paying attention to every minute detail as you do it. That's the difference between a simple practice and a deliberate practice. And what makes the difference between the two and what makes that huge difference is the feedback. They're both doing it in repetition. Repetition is great. But without the feedback and the critical thinking behind it, there's just simply going to continue to make those small little minute mistakes over and over again. And in EMS, we simply can't make those mistakes. And so the feedback and the recourse and the getting the understanding and critical and constructive criticism is key in order to make success with our training. So let's talk about how we're doing things now. Let's take a head injury patient, for example. Let's do this. We're going to be the training officer or the training coordinator, and we go up to a team, okay, 2 paramedics. And we say, okay, we're going to do this scenario. And what that scenario typically looks like is you do like a 45-minute, maybe an hour long, maybe even an hour and a half long scenario where you go from interaction to the handoff at the hospital. So it takes quite some time. And then you have to have that feedback and breakdown as well after it. That's typically what it looks like, meaning that you're going to get a head injury patient that's going to take an hour and a half to go from point A to the very end. But the problem with this is that all the feedback is at the very end of the scenario. And what's even worse about it is that we don't do any repetitions after that. So we get feedback, constructive feedback of all the things that we did good, but also all the things that we did wrong. And the nice thing is when we do repetitions is that we can improve on the things that we did wrong. In the standard that we use now, where we only do one scenario without a repetition, we don't get the chance to practice and improve on the things we did wrong. And here's another thing about that repetition. Not only is it going to improve the confidence and the mentality of that practitioner, it's also going to benefit them for when they don't see this patient immediately after they do the training. Because we know that when we're training these people and these practitioners, we're not training for that head injury to occur the next day. We're likely training for that head injury to happen a month from now, 6 months from now, maybe even a year from now. And so we need to use this repetition in order to retain the lessons being learned here. Or else if they're not retaining these lessons being learned, then there's no point in doing the training at all. And what's really interesting about this, and I wanted to bring this up because the repetition not only is going to improve the confidence of that practitioner, because we're not leaving on a negative note, we're leaving on a positive, successful note, is that we walk out of training and any lessons that we learn, we walk out, if this is time down here, and this is retention percentage here, we are able to retain about 90% of the information that we have during the lesson itself. As soon as we walk out, 15 minutes after, we lose about 20% retention. So we're already down to 70% 15 minutes after we walk out of that room. Okay, that's a lot of information lost. By the time we do 15 days, we've lost another 40 to 50% of that retention, leaving us with about 40% learned if we only do one scenario. But if we do the repetition, that completely changes. I'm going to show you that in just a second here. So how do we fix this problem with deliberate practice and repetition and feedback? There's a few ways to do it, but there's one very simple way to do it that doesn't add much time for you or any struggle for you for that matter. It's using repetitive practice to your advantage. And so typically when it comes to a scenario, like I said, it can be as long as an hour and a half long. What I would suggest, and what deliberate practice would suggest, because we're trying to save time here, we want to make sure that the time that we have is quality and less about volume. And so what I would suggest is making your scenarios about 45 minutes long, not an hour long. And what we would do is that we would do the full scenario and making sure that in that first scenario, we have very simple outlined learning objectives. So in this particular case, when it comes to a head injury patient, we'd have learning objectives like this, 3 of them. Understand the importance of BP management in a head injury. Understand how to decide when to intubate in a head injury patient. Understand the need for resuscitation prior to intubation in a head injury patient. 3 big, strong learning points. And if you'll notice, the first one builds the second one, and the second one builds the third one. And that's how you should be building your learning objectives, is that you should start with a foundation, and you should use that foundation to burn on your second point. And again, using that foundation of the second point to build on to your third point. And that's what we've done here with the learning objectives. And so we get that student, and we get that practitioner to do a 45-minute scenario that hits these learning objectives. And then after that particular scenario, we do a debrief. And the only thing we debrief are these learning objectives. We discuss how they did it, and we would review how we would do it, what we look for when it comes to the importance of BP management. We'll discuss their decision on whether to intubate or not intubate, and then we will tell them how we decide when to intubate these patients and how to manage that patient and what to look for. And then we would discuss their understanding of resuscitation, whether they did resuscitation or not for this particular patient. And then we would discuss the importance of resuscitation prior to intubation to avoid any dangerous hypotension in that patient. And so we're giving feedback. We're taking these small little things that they may have made mistakes on, and then we give feedback on how we would manage that. And after we do that, taking these 3 learning objectives, explain how we would do it and how they did better, how they can do better, we go immediately into a new scenario, identical or very similar to the first one, another head injury patient. So that way they can practice the feedback that you've provided. And then they can have a more positive outcome on that scenario. And that creates a lot of positivity for that patient or for that practitioner because you provided them a success as opposed to a negativity at just the end of the feedback. They get to challenge themselves. They get to improve on themselves with that second scenario. So that improves their mentality and their positivity with that scenario. The second thing it does, so we saw this graph where we saw a pretty steep decline after 15 days. Okay, we had a pretty steep decline because we only had that one time that we actually taught them that learning objective. If we repeat that scenario and allow and review those learning objectives and teach them how they improve themselves after that second scenario, we are actually going to see a much smaller decline. We'll still see some. Okay, time always we lose memory over time, but we see a much lower and less steep decline in that retention, which means that we're going to be able to maintain that. And so when this patient comes to them and they arrive at this head injury patient 6 months from now, they have remembered more about that training because of the repetitions than they would have if we only did one and gave feedback and that was it. And that's where deliberate practice really comes into play when it comes to EMS professionals. And that is how you use deliberate practice in EMS settings in order to train our next generation. So I challenge you, when you're training, and when you're training the new generation of paramedics, to use this training regime founded by Ben Hogan, to enjoy practice, to have positive outcomes of practice, and to make our practitioners near perfect like Ben Hogan was because of the diligentness of that practice. And we can teach that in our new generation of paramedics as education providers, as training officers, as the educators of this new generation coming up that's going to be the forefront of paramedicine.
Welcome, and thanks to everyone. I want to thank Flightbridge ED, Pulsera, EMS World, and thank you for putting together such an amazing conference. I'm actually a little bit humbled to be here because the speakers at this conference, these are the people that I learn from. I listen to their podcasts. These are amazing people. They're more than on the cutting edge. They're pushing that cutting edge. They're like butchers, whatever. These are amazing speakers, and I'm really glad to be here. So, who am I? Who the hell is this Delp guy? I'm an ER doc. I've been a stroke director, and I've been working with LifeLink as the associate medical director for about 13 years. They've graciously allowed me to do talks where I poisoned myself. I've impaled myself with various fish hooks. I'm kind of surprised they let me talk at all. It's probably why I'm doing this remotely. But I love this job. And the biggest reason I love this job is out of respect for what you do. I think that when I was thinking about that job, a story came to mind because I was at a party. No, I wasn't at a party. I was at a bar. It just sounds better if you say that you're at a party. And I was with a paramedic friend of mine, and she's a little rough around the edges. I can say that because I'm not very scared of her. I'm kind of scared of her. But this is an undisclosed location, so I feel pretty safe. So we're at a bar in West Duluth, and let's just say this is not the bar where the surgeons go. And there's a buddy of mine there who's got no medical knowledge whatsoever, and she's talking about this app to launch the helicopter. And he says, "Hey, you're just like an Uber driver." And I froze. And all those little warning hairs in the back of my neck started to go up. And she didn't disappoint. She said, "Yeah, I'm exactly like an Uber driver, except I fly there at 165 miles an hour. I land in a circus. When I get there, passengers rarely ready to go, and they're usually doing something, the passenger, that I can probably do better and faster. On the way back, I've got 32 things to do during a 15-minute flight, during which the passenger is figuring out all sorts of new and different ways to expire prior to me getting there. Afterwards, I have to write a 23-page paper about my trip where this guy can leisurely look through it and figure out something else that maybe I could have done. Oh, and no tips. Other than that, it's exactly like an Uber driver." And my friend was like doing the Bob Newhart blank, for those of you old enough to remember Bob Newhart. And he's like, "So why do you do it?" She said, "This is the best job I've ever had." So when we talk about what you do, I collect these cases. And I've been collecting cases for decades now, where the flight crews have taught me something or made a call that maybe I wouldn't have made. So I collect all of these different cases. And this is the case of little did they know. Little did they know that the patient would arrest in 8 minutes. And it illustrates a lot of problems about how we think about this job. In medicine, classically, there's a period where you gain information, you assess, you create a differential, come to a conclusion, a plan, and then you enact the plan. This is a lot of times how we dissect the case afterwards. But what we're actually doing is we're just creating a narrative afterwards, and that's not really how things go. We really can't evaluate like that. Often when I'm being presented cases that have come to my hospital by the flight crews, they want to know immediately, what did the patient have? And I don't really want to tell them, because that's not the point. The point is, did you get as much information as you could? And did you make the right decisions given the amount of information that you have? And sometimes the information is limited. That's like saying Elon Musk's doing okay with his finances. It's incredibly limited. And sometimes the information that you're given is just plain wrong. And that's also true in my field, where I'm going through and I'm like, Mrs. Gunderson, are you on any blood thinners? No. Are you sure you're not on any blood thinners? You're positive? Yeah, I'm positive. Mrs. Gunderson, are you taking the Coumadin that's on this list? Yeah. Are you aware that Coumadin is a blood thinner? Oh, yeah. So, the call is a 21-year-old male, type 1 diabetic, found down. Now stop. Already, I've just given you 4 facts. I've given you age, sex, a pre-existing medical problem, and a condition. And already, your mind is starting to work. How many thoughts did you have? There's thousands. I got to nerd this out a little bit because my daughter is a professional computer hacker and a computer scientist. And she was telling me about the fastest computer, which is the Summit computer that IBM has at Oak Ridge Laboratories, and that it can calculate 2,000 petaflops per second. And that's floating operations per second, and peta is 10 to the 15th power. So I looked up what our brain does. And the human brain can do 1 exaflop, which is 10 to the 18th power, so several powers of magnitude faster. And you're all starting to speculate what this case would be. Some of you have added a 5th fact, and that's the fact that I am presenting this case. So now you're starting to second guess. Is there something unusual about this case? What is this? Is this a zebra? Is this a horse? You know that bit of advice that they say that when you hear hoofbeats, you saddle up and you ride it until it's buying Louis Vuitton and Gucci. No, I'm sorry. That's my advice to my son for dating. But you get the point. You prepare for the routine, but you have to be ready for absolutely anything. How many ICU nurses do you know that know how to thaw out a frozen IV line under their armpit? It's all of this stuff it's not in the books, and you can't learn it except here at Flightbridge ED. So back to the case. Arrival. The clock starts. Little did you know that it's 8 minutes until this patient arrests. When we present the case, we usually start with vital signs, but that is a gross underestimate of how much is processed before you get vital signs. When you walk in, information starts rolling in faster than I think a lot of you realize. I like watching an experienced flight crew when they arrive to a critical patient because their eyes are darting all over the place, looking at everything. So the approach. You're watching the actions of the staff. Are they moving fast? Are they moving slow? You're also watching for anything else that's in the room. Is there maybe an emotional family member that may be a liability if they're incredibly angry, upset? As you approach the patient, even the sense of smell comes into play. As soon as you arrive at the bedside, is that ketones? Is that alcohol? Is that unmistakable aroma of a GI bleed? I have a buddy who's a gastroenterologist, and whenever I call him down for really bad GI bleed, he comes bouncing down to the ER and he walks in the room with me, and there's that unmistakable aroma of melena, and he put his hand on my shoulder and he goes, that's the smell of money, Delpa. That's the smell of money. So all of this information is flying at you, and people talk about Gestalt. I'd like to contend that there's no such thing as Gestalt. There's just gathering more information than you can possibly put data points to. When you walk into a room and an ER doc is just about to intubate the person, and they put the blade in and they freeze and look up like that. Now that's a data point. Now there's no place to chart how many millimeters big the ER doc's eyes were, but it is a data point, and you're going to act on that data point. You know it's going to be a bumpy ride. There's a PEDS study where we looked at pediatric sepsis, where we studied We didn't. They did. I take a lot of credit for stuff. Don't believe anything I say. So they were taking all of these pediatric patients and trying to determine which ones were septic. So they measured things. They measured white count. They measured the height of the temperature, their heart rate, all of these different factors to see which ones were going to be septic, or a combination of factors. And what did they come up with? Nothing, except for one thing. There was one parameter, and that's an experienced clinician saying that this kid looked sick or did not look sick. And again, is that Gestalt? No, these clinicians are looking at other things, thousands, not a dozen data points, but looking how the kid is interacting with the mom, how the kid is interacting with him, how all these extraneous things that you're absorbing. So the case, the setting, there's no doc in the room. You're thinking patient stable, maybe the doc's nervous, more critical patients in the ER. There's a female in street clothes standing in the corner. So she doesn't seem to be a liability, maybe a potential source of additional information. You look at the monitor walking in. It looks like a sinus tach at rate between 120 and 150. O2 sat of 98%. There's a temp Foley in. It reads 35 degrees. Nice to have a Foley already in. And the patient is undressed. Yes. Sometimes it's just the little things. So you're thinking about all these data points. There's one nurse, so this patient isn't requiring multiple interventions. They notice that she's pushing D50 as they walk in the door. So another data point. Patient obviously is not in DKA. So finally, you get to the patient. Intubated. Check the ET tube later. Orogastric tube. That's kind of nice. And the Foley, 2 IV lines. So you're ready for report. Elapsed time, 30 seconds. They now have 7 minutes and 30 seconds left. Nurse report. 25-year-old found down by a friend. Last known well 2 days ago with an initial glucose of 15. EMS gave D50, and when no response, they intubated the patient. History of type 1 diabetes. On arrival, they did a head CT and a neck CT, which looked normal. And they did a chest x-ray, which looks unremarkable. So you're starting to process all of this. Initial report, the age said 21, this is 25. That may or might not be important. You know that now he doesn't live with anybody because his last known well was 2 days ago. So you're thinking about the CAT scan. Do you need to wait for a formal read? Do you know the ER doc? Is he good at reading CAT scans? All sorts of things are kind of processing in through there. So there's additional time off the clock. 6 minutes and 50 seconds left. And you're screaming for just any more information because information is your ally, right? What was the neurostatus prior to intubation? A GCS of 3 versus 7 makes a big difference. Did they give RSI drugs? If so, when was the last dose of paralytic? Was there any more past medical history? Any other clues at the scene? Was he found down at the bottom of the stairs? And you're processing all of this and trying to only ask questions that are going to make a difference in what you're going to do. I mean, if they've got a seat collar on and they weren't found at the bottom of the stairs, you're going to remove that seat collar? Probably not. Even in the ER, if I've got a young female with low abdominal pain, mom's in the room, am I going to ask her if there's a possibility that she's going to be pregnant? Is that going to change whether or not I order a pregnancy test? No. So I don't even bother asking those kind of things. So you start your assessment while you're pumping for more answers, confirming that the tube looks okay. 2 IVs. While you're looking at the IVs, maybe checking for track marks. And you're asking all of these different questions. And the nurse says, wasn't sure what the initial GCS was, but she knows that they haven't moved since they sedated the patient with 5 milligrams of vecuronium earlier. Make a point to mock them using vecuronium later for sedation. So wait, what was the second glucose? You were giving an AMPA D50. Second glucose was 30. So take another 55 seconds off the clock. There's now 5 minutes and 55 seconds left. So your brain is still wanting more data, but you've got enough. You're on some familiar ground to begin and at least start your action plan. Persistent hypoglycemia, maybe accidental, maybe intentional. You're getting your D10 infusion ready, making mental note to when you're going to recheck that glucose, and the blood pressure cycles. First blood pressure was 110/70. Now the blood pressure is 70/40. And first, what I do whenever I get a vital sign that that is unexpected to me is I hope it's wrong. I live a lot of my life in hope. I hope that that person with the chief complaint of diarrhea for 10 years isn't coming to my pod. They do. I hope that when my wife hands me a cup of coffee and winks at me that there's not something wrong with it. There is. She put thicket in it again. So there's a dictum that the greater you hope a vital sign is wrong, the greater the chance that it is can be accurate. And that's the case in this case. The patient looked crappy, and their blood pressure is truly 70/50. So actions and interventions and discussion all happen at once. Quick discussion about shock as you're starting the IV fluids. Probably hypovolemic, his last known well was a couple of days ago, but mentioning distributive shock. Could this be sepsis? Sure. Could this be obstructive shock? No evidence for that. Maybe hemorrhagic. He looks pretty good. He actually looks a little flushed on exam. O2 sats are 100%. So still getting things going at the same time. Why the change? All of his blood pressures have been fine up to this point. So you're thinking, is there something that's changing with him? Or is this that case where it's a young person who adapts all the way to the very end and then falls off of that precipice? So fluids are open. You're getting your presses ready. Time to recheck some vital signs. Recheck the glucose. Recheck the glucose at 65. Recheck those vital signs. Blood pressure is now 66 systolic. Heart rate's 130 to 150 now. Little did they know, it was 3 minutes and 5 seconds before the patient would arrest. So they looked at the monitor, and they're not sure if they saw that before. The T waves look peaked. They definitely look like peaked T waves. Not sure if they noticed that before. So they asked for a stat EKG while they're pushing pressors, fluids, glucose. You get the EKG. And this slide is the only slide that I'll show you. And this is the EKG that they saw. At this point, the ER doctor comes in and says, "Oh my God, that's hyperkalemia. Give him insulin, glucose, bicarb, calcium chloride. I'll see if I can get K-Exalate from the pharmacy." And then he exits. It's like a cameo appearance. He doesn't come back. In a way, you're relieved. We know hyperkalemia. Hyperkalemia is that spouse of 10 years that you know how to make happy. An amp of this, an amp of that, a cocktail, a massage. Everybody's happy. Now the potassium comes back, and it is 4.5. Now it's time to think about how much weight to give data, weighted data. In medicine, it's not like other sciences. Like in engineering, you can say that pure aluminum has a tensile strength of 90 MPa, megapascals, for those who are nerdy. But in medicine, data is pretty flexible and fluid. Treat the patient, not the monitor. We often don't trust data. A sat and a 50, a patient who's pink and talking to you can just throw that data piece out. We unconsciously do kind of a pretest probability. And I know that a lot of you know how to do those kind of things. And I don't. Pretest probability, I've taken that class so many times. I call that fancy thinking. I'm not a fancy thinker. I'm more of an action man. I like to think of myself as more of an action guy, not a fancy thinking kind of guy. I was just reading this book called Thinking Fast and Slow, and my wife was walking by, and she just immediately, without skipping a beat, says, "Oh, I know which one you are." And yeah, that's probably true. But they gave me a great example once. If you have 1,000 10-year-old kids with chest pain in the ER that get an EKG, and if a few of them will show an acute injury pattern, and you get 1,000 men in their 60s that are smokers, and they get an EKG because they have chest pain, and some of those show an acute injury. The positives in the kids, you're going to question a little bit. Could this be a false positive? It's much more likely that that's going to be a false positive than the men in their 60s with chest pain. Those are probably going to be true positives. So you're filtering that data. So what happens when you have two data points that don't match? You've got peak T waves of potassium of 4. What are our tools? Well, our tools are appearance of the patient, the history from the patient, and you can repeat a data point. The biggest part of that, the history, has kind of been taken away from you because the patient is intubated. But frankly, sometimes talking to the patient really isn't that helpful. I had a great mentor, Dr. McPhee. He was Scottish, an old internist that taught me an awful lot. In one of his lessons, I remember very well, he said, "Sit down, I got a bit of wisdom for you." He'd make me sit down because he was very short, and then we were right at eye level. He said, "There's only two types of patients in this hospital. There's those that lie to make themselves appear more well, and there's those that lie to make themselves appear more unwell. And your job, laddie, is to figure out which is which." And that's true in our own clinical practice. You have a guy who's sweaty who says, I'm fine. My chest pain is nothing. And you have the guy who's like, "I'm dying here," as he's looking at his wife. Your approach to those people are different. Again, you're filtering data points, all about context. So in this case, a K of 4, but peak T waves could be in renal failure. He's been down for a couple of days. How good is the EKG versus if you're comparing it to a potassium level? We know that hemolysis can raise the potassium, so that could be a false raise. What lowers it? Maybe if you draw it above an IV line. So the crew's talking this over. How good is this? How much weight to give each data point? And afterwards, when I'm reviewing this with my crew, I can sit back and say, actually, about 28.7% of people with EKG findings consistent with hyperkalemia are actually normal kalemic. And that's one of the advantages of being a medical director with access to Google before you review these cases. But patients crashing, you need to just make a decision. And what could go wrong with an AMPA bicarb? So they give an AMPA bicarb. Looking at the monitor, it seems like maybe it's transiently improving. And there's a little bit of internal backslapping, high-fiving that's going on as they're starting to prepare the patient, thinking about what's coming up next. And all of a sudden, the alarm goes off and the patient arrests. It is now that 8-minute mark. So the first question of the crew is, did I do something wrong? They arrested right when I gave the AMPA bicarb. What's going on? But you have a plan moving forward. It's VTAC arrest, no pulses, ACLS protocol. So they move forward with it, moving forward with the ACLS protocol. Then what do? Well, you move forward with repeating stuff. Repeat potassium, it's 3.5. Repeat glucose, 75. Thinking about this, repeating a hemoglobin, 15. pH, 7.25. So continuing to move forward, giving the medications. Now we're on a couple more rounds of meds. And the crew starts to talk. You know, what other resources do we have besides our meds, our x-rays, our CAT scans? One more source, additional information. And this is where they stopped going forward. This is where they started walking backwards. There was a girl standing in the corner. The nurse goes over to talk to her, leaving the paramedic doing the CPR. Again. So how do you know him? What do you know about him? She just lives in his apartment, and they meet up together to walk to therapy together. Now you're thinking, therapy? What kind of therapy? Well, she's anxious. He's got anxiety and depression. Is he on any medicines? You know where this is going. You're starting to pump her. What medicine? I don't know any of his medicines. Can you remember anything? Well, he's been through a lot. They've switched his medicines multiple times. I don't. Maybe something that sounded like a girl's name. Amitriptyline? I don't know. Maybe. I don't know. So, maybe amitriptyline. Tricyclic and an insulin overdose? This kid was serious. He's not going to get any more dead. You're now continuing with your ACLS protocol, but add bicarb, 3 amps of bicarb, another shock, and now you get a pulse. Pressures are soft, but they're not mushy. Pressures in the 65, 70 range. So package this person up, bicarb drip. Get him to me where, frankly, I don't do much. I continue with the pressors, add a pressor, get him up to the ICU. And then we wait. He ends up going on dialysis with an acute kidney injury. He's intubated for a prolonged period of time. Eventually gets weaned off the vent. And again, eventually, he gets weaned off dialysis. And he leaves the hospital. And he actually comes back to the hospital and works briefly at St. Luke's as an operator for us before he moves away. That kind of decision density is just so incredible. So I thought about this case and about the job description, and maybe this would be a good interview question for potential candidates. Do you feel comfortable driving a boat at 50 miles an hour in uncharted waters, not knowing if your depth finder is working or not, and sometimes being told how to navigate by people who've never been on a boat? If you're comfortable doing that, then this might be the right job for you. So what I took from this and what affected my practice is continuously evaluating if things aren't going well moving forward, maybe I need to consider walking backwards. What the crew learned from this is that whole concept of weighted data analysis and how to explore weighted data analysis. And what we all learned from this is that I titled the talk wrong. Little did they know. I don't think so. They knew a lot. Thank you so much for listening. It's been a pleasure, and enjoy the rest of the conferences.